Hi, welcome. Today we're going to be doing the beginner's guide to coming off psychiatric medications. For those of you who don't know me, I'm Dr. Josef Witt-Doerring. I'm a board-certified psychiatrist who used to study drug side effects at the FDA. Now, this presentation is a culmination of what me and my team have learnt over the last 5 years at the Taper Clinic, where we have exclusively been helping people safely taper off psychiatric medications. And so if you are someone who's thinking about coming off psychiatric medications and you want to do it right the first time and you want it to be as painless as possible, you're going to get a lot out of this presentation. Okay, so who's this for? Well, it's for anyone who's taking a psychiatric medication and they want to come off it smoothly. So if you're taking any of these classes of medications, this presentation is going to help with that. So here's a roadmap of what we're going to be covering throughout the presentation. And let's dive in. So let's first start with why someone might want to come off. And having talked to hundreds of people, there are some patterns in the things that I've noticed people say are the motivations for them wanting to come off. So they'll say things like they feel blunted or disconnected from their feelings or other people. They'll say that they've lost motivation and they've lost drive to do things that they used to want to do. They'll feel like the drug has worn off now and it's not really doing anything. And then sometimes I get people who just deep down, even though they don't mind that other people take psychiatric medications, but deep down they feel like for themselves that they shouldn't really need them and that they want to come off of them. And then there's folks who have side effects. You know, they're trying to lose weight and they can't, or they're having sexual dysfunction. Or some people simply worry about concerns about getting the medications, especially people on things like benzodiazepines. They're worried the doctors are going to retire or that the doctor's going to have an about face and they're not going to want to give them medications anymore. Or they live in California and they're worried about, what if there's like an earthquake and all of a sudden it disrupts the supply chain and they can't get the medication, and they simply hate being, having their mood be reliant on a chemical. And so these are all the common reasons that people come to me about wanting to come off. Let's talk about that. How should you come off? And really the first place I think we should start this discussion is talking about why you have the symptoms in the first place. And this is because in order to get off the medications, you need to make sure that you're replacing them with something else. Now, a lot of people have been told that their mental illness is due to a chemical imbalance. That was certainly how I was trained when I went through school. And it was just like, it's mostly a chemical imbalance. And there can be some other things that go on. But the way in which it's really treated these days, especially in the US, is mostly like it's a chemical imbalance problem to be corrected by the medications. But that's not the whole story. And this is really relevant when it comes to getting off medications. So I like to think about the causes of psychiatric symptoms as coming from two places. It's a simplification, but I think it helps. There's the group of symptoms that come out of nowhere, and then there's the group of symptoms that come from life. And so when I say come out of nowhere, these are the stories from people who say things seem to be okay in my life, but I still just feel terrible. I'll go into a mania, or I'll have some psychosis, or I'll feel really depressed, or I'll feel very anxious on an edge. And it just feels completely out of proportional to the stresses going on in my life. If that resonates with you, you are a come out of nowhere symptom person. While certainly there can be some personality traits or maybe even some genetics involved for some of these conditions that could lead people to feeling that way, you can't stop there, because there's a lot of totally legitimate, real reasons why psychiatric symptoms can seemingly come out of nowhere. That's what this slide's about. So to start with, we've got medications. Yes, psychiatric medications themselves can make people feel worse. A lot of people will notice that the drugs start to turn on them and make them more anxious. They just impact them in negative ways. Stimulants can make people anxious. Benzos long-term can make people anxious, and so on and so forth. So the psychiatric drugs themselves can do it. And then we can't forget the non-psychiatric medications as well. You can have drugs like that modulate your immune system that are used for autoimmune conditions, or you could have drugs like statins that impair your cholesterol metabolism. And these medications can also make people feel unwell. And so you need to make sure that you're not missing any medication problems that are seemingly making your symptoms come out of nowhere. Then obviously we have medical problems, things like sleep apnea, infections, toxins. These could be things like heavy metals or molds, nutrient deficiencies like B12, vitamin D, and magnesium. There are legitimate medical problems that make people feel anxious and depressed. When your body gets sick, your mind gets sick as well. And you need someone to look at those things and not gloss over them, because if you can fix it at the root cause, it's a lot better than getting on a lifetime of psychiatric meds. So there's also a lot of food issues out there. Perhaps I think the biggest one is gluten sensitivity, which may sound crazy because you may think, oh, gluten sensitivity, that's just going to impair my gut. But up to 50% of people with celiac disease don't have gut manifestations. They actually have manifestations in different areas of their body. They can get very anxious and they can have psychotic symptoms as well. And so gluten sensitivity is no joke. So if you're someone where your symptoms are coming out of nowhere, a 4-week trial of a gluten-free diet could be life-changing for you. I can't stress just how big of a deal this can be for some people's mental health. The other big food issue that I see out there is insulin resistance. Now, this is why the ketogenic diet is so powerful. If you develop insulin resistance from a high carbohydrate diet, which is incredibly normal these days, it actually impairs the neurons in your brain. It impairs their ability to pull glucose into them, and your brain can become actually starved of glucose. And so what people find is that when they start doing a ketogenic diet, it actually improves insulin resistance and it improves the ability for the brain to energize itself. And people find that a lot of psychiatric symptoms go away. Probably the Metabolic Minds YouTube channel is the best place to go to hear stories about that. But Lauren Kennedy West essentially appears to have cured her schizophrenia. This is a big YouTube channel out there where she's sort of documented her journey doing this. And I've seen it several times in my practice. And so don't gloss over food issues would be my recommendation to you. If you're having psychiatric symptoms, have a good look at food issues. You only need to try them for a couple of months to see if they're helping you most of the time. And that can cure symptoms that seemingly come out of nowhere. Now, the final thing is just substance use. I mean, we have a lot of people out there who may be drinking like a pot of coffee a day, or, they're smoking or using nicotine products. And I'm not blaming you. This was me. I had a lot of mood problems from overusing caffeine and nicotine products, and also drinking, a couple of drinks every night. And it would impair my sleep and it would have me on edge. And it really put me on a roller coaster. And I would say this is probably the least investigated things by doctors these days, because these substances are so normalized. But I've seen a lot of people, myself included, really improve in their overall mental well-being when they get off the stimulant and alcohol sort of bandwagon and kind of move away from that. So that can be another reason for people feeling like their symptoms are coming out of nowhere. Now, the next section, symptoms that just come out of life. Now, these are the ones that are very intuitive, and I think this list will make a lot of sense to people. Obviously, anxiety and depression and psychiatric symptoms can come from stress in your life. And so when we look at the common problems, number one and number two are what Freud said. When they asked Freud, where does he think that mental suffering comes from? He said it comes from love and work. And he's talking about love relationship problems. And so that's things like problems, with your family or with your spouse or your children. But it can also be things like loneliness. They can have a big impact on anxiety and depression. Work problems could be things like, existential issues. I mean, you simply just don't like the work that you're engaged in, and you don't see a future there. You're going to feel bad when you're in an environment where you don't see a lot of promise in your work situation getting better. There are some things that are also really hard to solve. At least no doctor is going to be able to solve them. These can be things like economic problems or poverty. They can have a big impact on your mental health. You can have issues like trauma, one example of which is like childhood abuse, where the people who are meant to be looking after you and love you betray you. And then you carry those wounds with you for the rest of your life, and it impacts your relationships because you have a very negative outlook on other people and their behaviors because you've been betrayed. And trauma requires a lot of its own treatment. So you make sure that those experiences don't affect you. And then finally, there's grief, losing a loved one, a child, a spouse, will also cause symptoms. And so this is really how I break down all of the contributing factors to people being unhappy or having these psychiatric problems. And we need to address these things if we're going to get off medications. And so let's talk about how we would do that. Well, you would need to see a doctor. I think getting a medication review is a really good idea, making sure that none of the meds you're on are causing problems. Trying a paleo-style diet, that is a gluten-free diet. That focuses on whole foods. And there's some other things in there. Well, it focuses on whole foods and also getting rid of processed foods. That can be enough for many people to get them feeling better. You may also want to work with a keto coach, try a ketogenic diet. And then you also want to see a doctor. Now, you could see a normal doctor, but I would also recommend that people consider seeing a functional medicine doctor. And that's just because the functional medicine doctors in general spend a lot more time trying to get to the root cause of problems. They're going to look at nutritional issues, gut issues, infections, toxins, mold, all of that. And so I think a functional medicine assessment can be really great for someone who's having symptoms coming out of nowhere. You want to taper off any harmful substances that you're on. So these could be, stimulants, nicotine, recreational drugs. Therapy is obviously going to be great if you're having interpersonal problems. And so if a lot of your stresses are coming from trauma and how trauma is playing out in your relationships, or, you're just having, bread and butter relationship problems with your spouse, interpersonal psychotherapy can help you a lot. Coaching is something that could be very helpful if you're struggling in your work or in your career. You don't need to just see a therapist for this. You can go outside of the mental health industry and just find a job coach or a career coach or someone who could specifically help you with that problem about work and help guide you in a more promising direction. And the last one there is time. Time heals as well, specifically when it comes to things like bereavement, like the loss of a child or the loss of a spouse. Sometimes there's simply no way through that other than time. You need to go through the stages of grief. And so sometimes you don't need to just throw meds at something. It's just about supporting someone and letting that process of grief happen. So that's step one when you want to come off medications. You need to look at the reasons you're having those symptoms and start to address them, because otherwise the drug taper is probably going to fail because you'll start to remove the medications and those symptoms are still going to be there. The next step is, once you've looked at those root causes, is you want to remove any kind of substances that you're taking. And so we'll start with the stimulants. So if you're on caffeine or nicotine, I would recommend tapering off those over a month or two. And that's because they make you feel anxious. Same as alcohol or some recreational drugs. They just put your mood on a roller coaster where, as the drug comes into your body, you may feel a certain way, but then when the drug leaves it, you have increased anxiety. And oftentimes, if you're tapering things like antipsychotics or mood stabilizers or antidepressants or benzos, you don't want to be on a mood roller coaster where you have little spikes of anxiety and irritability during the day, because coming off those medications will put you into a state of withdrawal where you may have more anxiety. And if you're on something else that's worsening your anxiety, it's just going to make the taper harder. And so I would recommend tapering off those substances at a pace that's comfortable for you before you begin the taper. In general, we also just want to have healthy behaviors. So eat healthy whole foods and also try and engage in some light exercise as well. All of these things are going to help put your body in the healthiest place to tolerate a drug taper. Okay. So now that your body is prepared, we need to start thinking about what order you're going to remove these medications. Now, if you're just taking one medication, this is not going to be relevant for you. But if you're someone who is on a cocktail of medications, maybe 2, 3, 4, which is fairly common, you need to think about how you're going to remove these drugs. Now, there's no simple algorithm for picking which drug is going to be the best one to remove, but there are some relevant questions. And I think if you ask them, it will give you clarity on which drug to remove first. And so let's go into how you might weigh up some of these decisions. Well, the first thing to consider is removing the drug with the worst side effects. And so if you feel like a drug is really ruining your mood or it's causing a lot of problems for you, that's a good argument for targeting that drug and removing it first, because you'll actually feel better as you remove that drug. The next thing to consider would be to remove stimulants. So let's say you're on an ADHD medication or Wellbutrin, which are fairly stimulating drugs. So it would be better to remove the stimulant before you started removing a benzo. Now, the reason for that is that the stimulants can actually increase anxiety and they can increase insomnia. So if you started to remove the benzo, which is like a sleeping and anti-anxiety med, before getting rid of the stimulants, you're going to cause yourself problems, because now you've got the stimulants worsening your anxiety, and you also have the withdrawal from the benzos worsening the anxiety. So you're actually going to do a lot better if you remove the stimulants first completely and then remove the benzo. And so there can be sort of these orders that make sense. The next thing to consider is to remove the most dangerous drug first. And so I think this is relevant when maybe you're not really having an obvious problem with a drug or a really serious one, but let's say you're on maybe Prozac, an antidepressant, and an antipsychotic, and neither of them are really impacting you that much. You would remove the antipsychotic first, and that's because that's the drug that has worse metabolic side effects. It's the drug that can cause tardive dyskinesia, which is a permanent movement disorder. And so it would make sense to mitigate your risk by getting rid of the one with the worst side effects first, if there was no other reason kind of influencing the decision. And the final thing that I would also consider is to think about actually removing the drug that was most recently started first. And so let's say I get a lot of patients that come to me, maybe they're on a benzo and they've gone through a withdrawal and they had a really hard withdrawal and they went to see a doctor because they were suffering and the doctor put them on an antidepressant and like Lamictal and it just made them worse and it didn't really help because really what was going on with the person was they were getting pulled off the benzo too quickly. And so they'll turn up at my office on like Lamictal and Lexapro and like a benzo, which they've been on for 10 years. What I would do in a case like that is I would just kind of updose the benzo, stabilize them there, and then I wouldn't touch the benzo. I would remove the drugs that were recently started because, if someone's only been on that medication for like a month or two, it's way easier to pull it off at the start before their brain has really adapted to it. And so I think there's a special category as well where, if you've been on like a drug for 1 to 2 months, or 3 months, something like that, you might consider just leaving everything else the same and just removing that drug first and then kind of concentrating on the one that you maybe really wanted to get off that you've been taking for a long time. These are the questions that you should be asking when picking the right order. And now let's talk about like a frequently asked question, which is, can I taper 2 drugs at the same time? Because yes, sometimes people are like, well, I can't really, both of these things are bad. And I don't really want to put it off. And the answer is essentially, yes, you can taper 2 drugs at the same time. But what I would recommend is that you start tapering one drug first and you make sure you can handle that taper. And then within like 2 to 3 months after you're really established on that one drug, that you start to introduce tapering the second one. Tapering 2 drugs can be a little more risky because 2 drugs at the same time, twice as many withdrawal symptoms, but it can make sense in specific situations. Now that you've decided which drug you are going to taper first, you're going to pick the speed. And this is quite straightforward. So the majority of people are going to start with a 5 to 10% reduction every 30 days. It's just the easiest way to do this. It doesn't mean that you're going to be on that rate the whole time. It's just where you start to sort of level set and just see how you tolerate the reductions. There are a few exceptions to this. Well, there are a few exceptions to this. And the first one is obvious. If you're having a severe adverse reaction, now I think about people who may have a condition called akathisia, which is where they pace a lot and they have severe, intense anxiety. You're not going to do a slow taper, where you remove the drug over like a year and a half. You might remove that drug in a month. And so if you have a really clear, severe adverse reaction, you're going to taper a lot faster and your doctor is going to help you with that. Or if you're taking a stimulant. Now, most stimulating medications, they don't need to be tapered slowly because their withdrawal tends to be a lot more tolerable. And so if you're coming off like Adderall or Ritalin, mostly you can get people off these in a month or 2, sometimes even faster than that. People just tolerate the withdrawal symptoms well. It's a lot of like fatigue and sleepiness and you feel less cognitively sharp. And yes, that doesn't sound ideal, but I tell you what, it's a lot better than coming off a benzo quickly where you develop insomnia and anxiety. So stimulants like Adderall, Ritalin, and also kind of Wellbutrin, although some people do have to move a little slower with that one. They can generally be tapered off within, 1, 2, 3 months, somewhere in that range. But for all the other medications like the antidepressants, mood stabilizers, antipsychotics, you're going to want to be starting at that 5 to 10% reduction every 30 days. And then we'll talk more later on about how you're going to adjust that. So now that you know the speed that you're going to be going, you need to figure out whether you're going to taper with tablets or liquid. There's a lot on this slide, but the main thing that I want to share is that tablets are better for people who are on higher doses. And if you're on like a medium dose of a medication or a low dose of a medication, you're going to be better off using a liquid. And what I will also say is that most people should be finishing their drug taper with a liquid. And so let's go over this. So with the tablets, one of the biggest downsides of that is you're really limited by the fixed tablet sizes for your reductions. And that might not be a big deal when you're at a high dose, and people generally tend to tolerate the reductions better. Tapering with fixed tablet sizes is fine. But eventually when you get to the lower doses and maybe you need to cut a tablet with a pill cutter to do a smaller reduction, that gets really fiddly, especially when you're moving below like quarters on a tablet. It's okay to cut a tablet into quarters. You can do that pretty quickly and reliably. But anything lower than a quarter is sort of fiddly. And then people start getting into, they buy scales or they get nail files to grind down the tablets. And it's just a pain. And so that's why I only recommend using tablets for people who are on really high doses of the medications, and everything else is way faster with a liquid. And we will be going into why using a liquid is so important later on. The main cons of using a liquid is mostly that doctors aren't that familiar using them. And you also have to use a compounding pharmacy to get a custom liquid made. But if you get over that hump of finding a doctor who has an open mind to using a liquid, things will be much easier for you in the long run. And I've got some things in this presentation that really go over sort of how to write the prescriptions for these liquids to help you and help your doctor out. Okay, so frequently asked question here, what about the drugs with the special coatings where you can't kind of cut the tablet sizes? And they don't come in liquids. And so this is Effexor extended release, Pristique, Cymbalta, and Invega. Well, for the Effexor extended release, you're going to have to just swap to the generic instant release Effexor. So that's pretty easily. And for Pristique, now this one, you're going to have to swap over to Effexor extended release is probably the best way to do that, because the lowest dose size for Pristique is like 50 milligrams, and you can't grind that capsule down. For Cymbalta, you have two choices. You can either count beads, which is pretty time consuming, or you can try and cross over to Effexor instant release. Just a comment, with Pristique and Cymbalta, why we cross to Effexor is that Effexor, Pristique, and Cymbalta are all SNRIs. It's a sort of a subclass of antidepressants where they have norepinephrine tone. And out of all of those three medications, Effexor is the only one that comes in a tablet form where you could kind of grind the tablet down, or you could also turn it into a liquid. So that's why we're trying to move from Pristique and Cymbalta to that instant release Effexor version where you could do a liquid taper with that if you wanted to. Invega, this is an antipsychotic tablet that comes in a coating, and so you can't break down those tablets. With that drug, you're going to swap over to Risperdal first. And so what just came up on the screen is just the rough conversions when you do that transition with your doctor. Okay. So now that you've decided whether you want to use tablets or liquid for your taper, you need to decide how you're going to do your reductions. And so there's two types of reduction sequences that we use in drug tapering. One of them is called cut and hold. And this is essentially where you reduce the dose all in one go, and then you wait 30 days, and then you would reduce the dose again and wait 30 days. Often contrasted against microtaper or a liquid microtaper, where you actually reduce the dose every day. And so a good analogy would be to think of, jumping down 30 steps at a time and sort of like resting and soothing your knees before jumping down another 30 steps at a time. That would be cut and hold. And then the liquid microtaper being, taking it one step at a time, which generally tends to be easier on the knees, but it's a little bit fiddly and a bit more time consuming. And so going back to the cut and hold. So cut and hold works well at high doses. And this is because people accommodate reductions at high doses much easier than low doses. And so doing these types of reductions just tends to be easier at the high dose ranges. But once you get to the lower dose ranges, doing a cut and hold, it's really easy to overshoot the mark with the taper and accidentally put yourself into withdrawal, because you're going to be dropping fairly large amounts at a time. And again, put a pin in this for now. I'm going to be discussing why this becomes a bigger problem at the end of the taper soon. So here are some examples of cut and hold tapers and how I use them in practice. And so one good example would be if someone's on a high amount of Seroquel. So because Seroquel tabs, and you can kind of see them, they're the ones in the top right, they come in 25s. That's a really small increment. And if someone's on 800, it's going to be really easy just to taper them down quite far with the tablets. And so you don't need to muck around with any liquids. And so, you would get, maybe 3 200 milligram Seroquel tablets, and you would get 8 25 tablets. So you'd have to get your doctor to prescribe those. And then you might just decide to drop 50 milligrams every 30 days. And most people are going to tolerate that reduction just fine. Now, it's only once the dose is going to drop below 250 milligrams that you're going to start to have a problem with using those Seroquel tablets, because 25 divided by 250, that's 10%. And so if you're going to drop by a tablet at a time at the 250 milligram mark, you'd be dropping by 10%, which is generally kind of on the upper edge of where people tolerate. So once you start to get there, you're going to have to start pill cutting the 25 milligram tablets or quartering them, or transitioning to a liquid. Another example that I think makes a lot of sense for cut and hold is with something like Valium. Now, let's say you were taking 28 milligrams of Valium in 14 milligram doses twice a day. You could get your doctor to prescribe you 10 milligrams times 2 plus 2 milligrams times 2, and that would give you the 28 milligram dose. If you look over there on the right side of the screen, the white tablets, those are 2 milligram diazepam tablets. Now, you can quarter those fairly easily with a pill cutter. And so you could actually drop by half a milligram from each dose and the evening dose for every 30 days. And that would be a very reasonable way to taper. However, once you started getting to around the 10 milligram daily of Valium, you would start to, again, be sort of getting to that point where each reduction would be at 10% or more. And so that would start to become a problem area where you would want to start transitioning onto a liquid. I've put this Xanax up here on the top here just to show you something. Most of these circular tablets, they're quite easy to quarter. But this Xanax oval is really only able to be halved. So you have to look at the tablet to really know whether you could quarter it or halve it. And, that half a milligram Xanax one really can only be halved. So the next method for tapering, as I'd mentioned, is the liquid microtaper, where you reduce the dose on a daily basis using precision syringes. This is the way everyone should be finishing their taper, unless they're like on a stimulant, and it's a lot easier to drop off. But antidepressants, benzos, antipsychotics, mood stabilizers, finish them with a liquid microtaper. It's a lot smoother at the end and allows you to do smaller reductions. And as I had mentioned, the con is that you need to get your doctor to prescribe this for you. So if you were to get your doctor to prescribe this for you, I've put some examples of scripts up for how they would write it. And so what you're going to do is essentially divide the dose that you take by 6 ml, and that's going to be your concentration. So if you take Valium, 10 milligrams once a day, it's going to be 10 milligrams divided by 6. Let's say you take Xanax, half a milligram twice a day, it would just be half a milligram divided by 6, and so on and so forth for the 3 milligram dose. And I know there's someone out there who really wants to know the math behind this and why this works. And so I'm going to just briefly discuss why these are the concentrations that I recommend. There's a million ways to set these up, but I think this is the simplest. These concentrations are based off syringes, which I'll show you on a screen in a moment. And the smallest increment on a syringe you can change is 0.01 mLs. And the reason why we divide the doses by 6 mLs is because if you removed 0.01 by 30 days, you would get a reduction to 5.7. If you started at 6, that equals essentially a 5% reduction. You've lowered the ml dose by 5%, which is great because that's really where we want to start with a lot of these tapers. Now, as for the volume, as you saw on the previous slide, we had these volumes. If you're doing daily dosing, you need 180 mLs for 30 days. If you're doing twice daily dosing, you would need 360, and thrice daily dosing would be 540. That's just some simple math here as well. With single day dosing, you would just have 6 mLs, and you do that times 30 days, and that would be 180. And so if you add an additional dose, you need more liquid. So just to summarize it, the reason we calculate the concentration off 6 mLs is really because of the syringe. Now, here is the equipment that you're going to need to use to do a microtaper. So we recommend the Baxa brand syringes. You can get them on Amazon in the US. So you need a 5 ml syringe and a 1 ml syringe. And that's what you're seeing here. You need an adapter cap. That's a little cap that you can put on the bottle the liquid comes in. So you can turn it upside down and kind of get a syringe and stick it in there and pull it. And a magnifying glass, because sometimes these little lines here, each of these little spaces corresponds to 0.01 mLs. And sometimes that can be a little tricky to see. So having a magnifying glass can help. Now, I know this is probably getting really technical for a lot of people, but I want you to just think of what using these two syringes allows you to do. So this little syringe allows you to kind of, in a controlled way, lower the ml amount by 0.01 each day. And so this big syringe here, this 1 ml syringe has 100 spaces, right? And then this syringe here, this 5 ml syringe is essentially 5 of these 1 ml syringes. And so what that means is you actually have 600 spaces until your taper is over. And so if you just removed one of these little spaces per day, your drug taper is done in 20 months. I know that probably sounds like a long time for a lot of people, but it really is the right way to lower your medication, because I see a lot of people, they taper quickly, but they don't understand that their brain has adapted to the drug over the last 5 years or several decades or however long they've been taking it. And so removing the drug in a controlled way over 20 months is really the best way that you can allow your brain to readapt to the absence of the drug. It's just a very smooth way to lower the drug down. And that's why we recommend using these syringes. Essentially, with all of those tapers that I discussed on the previous slide, the way it works is you start by removing one of the tiny spaces on that 1 ml syringe each day. And you just keep on doing it until you hit 0. And then the taper is done. So if you remove one little space a day, you're moving at a 5% reduction from the original dose. If you want to move faster, you can remove 2 spaces a day, then you're moving at 10%. And if you were to slow the rate down, essentially you would remove 1 space every other day, and that would put you at a 2.5% reduction. A couple FAQs on this one is, do I need to recalculate the concentration every 30 days? And what this means is do I need to get a new script from the doctor once I'm at, a lower amount so it stays at exactly a 5% reduction from the new dose each time? And the answer to that question is no, I do not recommend that you do that. I recommend that you simply keep the same concentration and just lower it down until you hit a point where lowering it by the 0.01 increment isn't working for you anymore and it's starting to cause withdrawal. At that point, you could go back to your doctor and you'd be at a new dose, and you could then dilute the concentration more using essentially the same instructions here, where maybe your original dose was 6 milligrams per 6 ml. And now you're on 2 milligrams. And so you would just do 2 milligrams per 6 ml, and that would give you a more dilute concentration to allow you to continue with your taper. So once you get started with your taper, you may want to put together a table like this. This is just an easy way for you to keep track of when withdrawal symptoms will kick in. And so as you can see, you have the days on the left, and you can have the dose in mLs, and then you can also have the total daily dose going down. I like to keep a column on the far right side where you can just kind of gauge your withdrawal symptoms on a scale of 1 to 10. And this will let you know if withdrawal symptoms are creeping in. And using a table is just very effective because you don't have to rely on your memory. You've got the data in front of you. So now let's talk about tapering modification. The first question is, why do we want to modify the rate of our taper? Well, we want to do it for a few reasons. First, we want to avoid walking into severe withdrawal. So if the withdrawal symptoms are creeping in, you'll need to slow down your rate, because it's a sign that your brain is not adapting to the reductions at the speed at which you are reducing. So you need to slow down so you can match the rate that your brain can adapt. But the other thing is also about finding the fastest rate that is safe for you. So if you're tapering and you're doing well, you may increase the rate because you can accommodate faster reductions. By adjusting the speed of this, you really are finding the safest rate for you personally to come off the medications. When it comes to taper modifications, there's 4 options. You can speed up the rate, you can slow it down. You could do a hold where you just hold at the current dose. That's especially if you start to have some withdrawal symptoms, or you can go up on the dose. Now, I've done kind of a modified traffic light analogy for this, and that's because there is no light green on a traffic light, but I think the metaphor still holds. And this will tell you how to modify your tapering speed. So I'll call this light green. So if you are light green, that means you have no withdrawal symptoms at all. And what you should do if this is happening, so let's say you've done 30 days of reductions at 5%, you're having no symptoms at all, speed it up. And generally, I recommend you could jump by 2.5% per month, or you could jump by 5% per month if you wanted to speed it up. And so if you're having no withdrawal symptoms, I would recommend speeding up the tapering rate. If you are in the green zone, so this is just traffic light green, you have very mild withdrawal symptoms, but they're not impacting your daily life. If you're in the green zone, stay the course. Do not change the tapering rate. Just keep it as it is. If you get to the yellow zone, and this is where you start to have moderate withdrawal symptoms, and so they're very noticeable, but they're manageable. These aren't symptoms that are making you miss work or you're failing to fulfill your family obligations. If you start to have moderate withdrawal symptoms, you are going to hold your rate. And so you're going to stop tapering. You're just going to leave it steady until the moderate withdrawal goes away. And then you're going to slow your rate down. So you might drop it down by 2.5% per month. If you hit red, if you go into severe withdrawal and it's getting to the point where you're not able to work or fulfill your household duties, what you should do is you should go back, 14 days or 30 days in your taper and hold the dose there while the symptoms settle down. And then you're going to slow down your rate when you do decide to taper again. The final thing that I want to discuss here is probably what is the most common mistake that people make with tapering. And that is jumping off at too high of a dose at the end. So let's say you're on Valium and you get down to a 0.5 milligram of Valium and you say, well, this is 0.5 milligram of Valium, I'm just going to jump off. That's a mistake. Another mistake people make is that they start their taper and they're doing really well, and maybe they're dropping at 20% and they've done that month after month after month and it's fine. And then they get to the lower dose range and they keep on trying to drop at 20%. And they start to have a lot of withdrawal symptoms. And then they start to think, well, I can't come off this medication. It's my underlying condition. Or, this is just not meant to be. I can never get off. I just need to stay on these drugs forever. That's a mistake I see people make as well. Now, here's why they make the mistake. They make it because they're not aware of the principle of, hyperbolic tapering. And I know that's a complicated word, and so I'm going to try and simplify it for you. What this theory means is essentially that as you get to the lower doses of the drug, you need to remove smaller and smaller amounts. And these images kind of show that. So what you're looking at in this image on the left is two neurons, and it's the synaptic cleft, which is the space between two neurons where they secrete the neurochemicals like dopamine, norepinephrine, and serotonin. And so that's what's happening in the space between the two neurons. So the neurotransmitters are these little kind of reddish dots, and they are interacting with these receptors, which are these green ovals. Now, when you take a drug, you actually introduce something else into the synaptic cleft. And now for this example, we're talking about an antipsychotic medication. And that's what these little yellow blobs are. These little yellow blobs are blocking these receptors, which are meant to be transmitting the signal from the dopamine interacting with them. What is actually happening at the synaptic cleft as you get lower on the doses is that there's going to be less and less dopamine there. Now, this image doesn't show it because it's only showing the antipsychotic bound to the receptor. But really what's happening is this whole space here is going to be filled with these antipsychotic drugs just kind of floating around, blocking these receptors. And now the thing is, when you're on a high dose, if you say, you did a 20% reduction and you removed 20% of these little yellow blobs, there's still plenty of antipsychotic floating around this synaptic cleft to block these dopamine receptors. And so you may not experience much withdrawal or much change in your mood because there's just this excess of drug floating around. But as you lower the dose more and more, there's less of this reserve of the antipsychotic just kind of floating around in the synaptic cleft. And then you eventually hit a tipping point where there's not a lot of the drug there. And then every reduction that you do is actually going to be uncoupling these receptors. So what you'll find is when you get to the lower dose range, a lot of these receptors, the drug is uncoupling from them. And then people will start to experience way more physiological change from the drug disappearing. And so that's why when you get to the lower levels, you have to slow down the rate because there's less reserve of the drug in the cleft. This graph on the right kind of shows you an example of receptor occupancy and how that changes over time with Effexor. So the receptor occupancy percentage is just how much of the receptors are being occupied by the drug. And so 4 out of 5 here. So that's 80%, right? On this image on the left. And what they've done is they've mapped how receptor occupancy changes as the dose goes down. And so what you see here on the y-axis is the receptor occupancy with 100 at the top and 0 at the bottom. And what you see here is the dose of the drug. And so when the drug is at a high dose here, you can see that we have a lot of receptor occupancy. But even once we've almost halved the dose, we've halved the dose, your receptor occupancy is still at like 80%. Only once we start to get down to like the bottom fifth of it, where we start to uncouple these receptors here, a lot of them start to uncouple from the drug, and then the receptor occupancy just plummets. What does this mean for you? Well, what it means is once you get to the lower dose ranges of the drug, you need to move slowly, and you need to make sure that you don't become discouraged if you can't tolerate the same rate of reduction. That is normal. That is a completely normal thing that happens to everyone. Just take a breath and just lower the rate of reduction. Just keep on lowering it down until you find a rate that you can tolerate. Now, if I were to go back and we were to look at these syringes here, let me tell you how this might look like in practice. Okay, so remember how I said there's 100 spaces on this 1 ml syringe, and you're going to use a 5 ml syringe plus a 1 ml syringe. You're going to take 6 mLs every day when you start. So, you're going to fill the 5, and then you're going to fill the 1, and then you're just going to start dropping down one of these little spaces every day. How this could look like in practice is you might find that you start at removing 1 per day, and then 30 days later you say, well, that was really easy, I'm going to go to 2. And then 30 days later you can say, well, now I'm going to remove 3 spaces a day. And 30 days later, 4 spaces a day. 30 days later, 5 spaces a day. And you might find pretty quickly that you can remove 5 spaces a day without any problems. You might do that all the way until you get down to maybe to 3 mLs a day. And then you say, well, now I can only remove 3 spaces a day. That's where I'm at. You might be able to do that all the way until you get down to 1 ml. And then you decide that, I can only do, 1 space a day. And then when you get to half an ml total dose, you might decide, well, actually, I can only do 1 space every 2 days or every 3 days. And so that's how this process will work as you go down. You'll end up adjusting the rate at which you remove the drug. And that is totally normal. And that's the way it happens. And so there you have it. That is my beginner's guide for how to taper off any psychiatric medication. These instructions should help you get a lot of the way towards coming off these medications, hopefully with your own doctor. But if you are someone who has a more complicated taper, maybe there's some protracted withdrawal going on, or there's multiple medications, or maybe you've tried this and failed. If you live in the US, you should come and check out our website. It's taperclinic.com. And we help people with complicated drug tapers. And so if that is you, or you're simply someone who just wants to get this done right, and you want the peace of mind of working with an expert team that does this every day, we would love to hear from you. So check the link below this video for our website if that is something that interests you. And finally, I'd love to get your feedback on this video. Was there anything that I missed? Were there any FAQs or other questions that I left out? Leave them in the comments below this, and I'll make sure I integrate them in the next video that I do about tapering. If you like this topic and you want to learn more about some of the reasons why you might want to come off medications like antidepressants, you might want to check out this video over here where I talk about some of the problems with taking antidepressants long term.